Good afternoon, everybody. Wow, what a day, huh? Has everybody been learning, growing, expanding your ideas? I have been just blown away by the amount of dedication and commitment to this group to really, truly make progress in our healthcare system. So thank you for joining us and staying with this session. My name is Libby Hoy. I'm the founder and CEO of PFCC Partners, and I'll be moderating our session today. On today's panel, we're going to discuss how to better engage people, family caregivers, and others who are engaged in accountable care relationships to make care truly accountable and responsive to the needs of the individual. We will identify examples of ways in which payment reform can incorporate and empower individuals. Please note that when we're referring to people or individuals, I may call them patient-family partners. That could include patients, family caregivers, and other individuals who encounter and engage with the health system. So just to tell you a little bit about myself and how I came to be here, I came to healthcare and healthcare improvement. I sort of was drafted. As a young person, as a teenager, I became my mom's family caregiver for her as she battled breast cancer. And shortly after she passed away, I had my own family. I had 3 boys who live with mitochondrial dysfunction. So we are that high-end user, 38 surgeries across the country, thousands of therapy sessions, physical, speech, every which way. And then finally with my own journey with stage 4 salivary gland cancer in 2016. So those are my credentials. That's all I have. I'm a person with lived experience who has navigated the health system for a very, very long time. And have seen some growth and some changes, but also deeply concerned about some gaps that we have. And really that's what prompted me to start Patient and Family Centered Care Partners is acknowledging that I am an educated white woman of privilege, and I roomed with people who didn't speak English as a first language, and I held a mom while she cried because the surgeon explained a very intricate surgery. She didn't understand a thing and had to sign that consent form anyway, right? I had my husband who, when things went bad, was emotional and upset and vocal. He was allowed to be. The black man who was rooming with us, who did the same vocalizations, was not. The security was called. And so that's our mission as an organization. We really seek to open space for people with lived experiences, communities. I hope you all heard that HEAT panel earlier today. That was phenomenal. Really opening that space and engaging patients and families. We are that one continuous thread across all the settings, from the payers to the physicians to the clinicians. We're the single continuity, piece of continuity. So it's exciting to me to think about how we might invite people with lived experience into these processes, learn with them, and leverage that as a key strategy moving us forward. So I do think that the opportunities we have, and a lot of what we've heard today, the opportunities live in the spaces between. They live in the spaces between our payers, between our health systems, between our clinicians, our nurses, our beleaguered workforce, right? And we, people with lived experience navigating the health systems, we're the ones in those spaces. We have critical insights to share with all of you as you develop these models. And so I'm very excited to have the HCPLAN launching the Patient Perspective Council. I think that's going to give us an avenue in to bringing, again, the experiences of people with lived experience and in communities into the work that all of you are doing. We're so eager to be helpful to you. We're so eager to partner with you and really think through how we can reduce costs, not only for the health systems, but also for the people, right? For the people. So I will say that when I joined the HCPLAN, I think it's been 4 or 5 years, we had a network of patient family advisors like myself, about 300 people. Now we're over 1,000, with a strong focus on inclusion to create diversity. Take advantage. We're here for all of you. So I'm so happy to be here with the co-panelists and really hear about the work that you've all done in this engagement space. So joining us today is Brandon Wilson, Senior Director for the Center for Community Engagement and Health Innovation at Community Catalyst, an organization that's focused on reforming health by addressing structural racism and other inequities. And it's been such a pleasure to get to know you already.
Absolutely.
We're also joined by Christina Severin, President and CEO from Community Care Cooperative, C3, an organization whose mission is to leverage the collective strengths of federally qualified health centers to improve the health and wellness of the community. And you won't find many more people more passionate than Christina. I've only known her for 30 minutes, but I feel her passion. And we also have Dana Gelb-Safran, President and CEO of the National Quality Forum, where a big focus of their work is developing patient-reported outcomes, tools, performance measures to better understand how to improve patient experience and quality of care received. And of course, there's more in-depth information on the conference app. And I will also say that I've had the great pleasure to be able to collaborate a bit with Dana and her team. So again, we're all so lucky to have everybody here. All right, so Brandon, one of the key components of intentional and thoughtful person engagement is to understand the health-related social needs to effectively improve individual outcomes and combat disparities. Can you provide some tangible examples of how person-centered strategies are being used to address health-related social needs and disparities?
Yeah, absolutely. Thank you for that question. If I can start first on centering around person-centeredness. So I think it's sometimes we throw that word or that term around without unpacking it. And sometimes it can sound like a luxury or a nice to have. But we've done some research, and I can tell you it's imperative. Those who believe that they've received person-centered care, it is increasing, but we're seeing wider disparities amongst who believe that they've received it. More Hispanic and Black Americans are indicating over time that they believe they've never received it. More white and Asian Americans are stating that they have. We've also know that when you or believe that you've received it, it's more likely that you've received more preventative care. It's more likely that you have better control of chronic conditions. You have higher satisfaction, and you have lower projected costs over time. So what does person-centered care looks like when addressing social determinants of health or health-related social needs? I think there are a few tactics and strategies that are being used. I think one of the most common is, of course, the screening for health-related social needs using health equity assessments. I think we just came out on the end of some of the accountable health community model results. What was pretty interesting with those results is one that we did see, although for Medicaid, Medicare fee-for-service beneficiaries, statistically significant reduction in avoidable ED utilizations for both of those populations. What we also saw was that when they interviewed persons or beneficiaries, that they felt as though that there were benefit to receiving navigation. There was no results or impact or being able to detect that amongst the effectiveness of the navigation itself. We think the hypothesis is that we could have included a whole lot more investments in community resources so that the needs could be met once they were navigated. This is where I think real patient engagement and community engagement comes in at. And I'm going to critique myself because I worked on that model. Had we talked to community, had we talked to patients up front, they probably would have told us that if you're going to increase screening and if you're going to increase navigation, you're going to have to equally increase resource investments into communities. People who live in communities with housing needs can probably tell you that we've already probably gone to most of the CBOs, and that trying to navigate housing resources is limited and challenging. And, which not in any report, it's my own hypothesis, is that particularly in certain communities, rural communities, small areas, if you're not thoughtful in working with CBOs, you could be developing new disparities or exacerbating existing disparities if it's a certain population who's only having access to your touch points. If it's primarily, going to throw out population, if it's primarily white males who haven't access to primary care, to behavioral health, they're not just going to get screened and navigated. And you could experience resource saturation really quickly. So overall, I think screening is a wonderful thing we can use. It helps us make data-driven decisions, particularly data that includes perspectives from beneficiaries and patients and family caregivers, and using them as the first reference point to actually validate and determine what rigor really is as we design out models.
I love that. I think, as we think of one human entering the health system, that human's creating revenue. A person accessing a CBO is decreasing that revenue, that financial, yeah. Awesome, thank you. Christina, did you have anything you wanted to add to that before we move to your question?
I would add, I could not agree more. It's really well said. In a core part of C3's business is in Massachusetts, where we're fortunate to have an advanced Massachusetts Medicaid branded Mass Health Accountable Care Organization program. And in that program, there are dollars through the 1115 waiver to support individuals in actually bringing resources to bear to fulfill, again, something that was revealed in a screening tool. So for example, if there is a family, and let's say it's the mother's experience with the healthcare system, and the mother says, yes, there is an issue around access to food or adequate nutrition or cooking equipment, that we are able to then refer that person to a partnered community-based organization. And that community-based organization can provide that mother, that family with those nutritional supports or the customized support that family needs. The early returns look very good in terms of the percent of referrals closed looped, where the services were received, what the impact has been on the quality of the person's life, key measures of condition status for the individual, like a hemoglobin A1C well controlled, and key measures of cost, like total cost of care per member per month receiving the intervention in a period up to 6 months post-intervention.
Thank you. And can you talk a little bit about how the FQHCs are being reimbursed to effectively address engagement of people with complex needs, and what ideas you might have about improving that?
Yeah, absolutely. A couple of thoughts would be in the big picture here, where we have health centers in 50 states, that they are all paid something called, I'm sure most of you know, the prospective payment system, so-called PPS, which is good because it tries to get the methodology that the federal government created in creating the PPS was that health centers for Medicaid should be reimbursed the cost of what it takes to deliver their services. The problem is that it is left up to the state Medicaid authority to set the PPS and then keep the PPS current based on the federal rules. And as a practical matter, there's probably approximately 48, 49 states where the health centers are dissatisfied or in the process of trying to negotiate or escalate a negotiation around trying to get a fair PPS. And this is important because health centers have limited organizational capacity due to a lot of complex reasons. And when they're spending a lot of organizational capacity trying to get a fair rate, it takes away from the other work that they could be doing. Part of me, but again, I'll use Massachusetts as an example. Massachusetts health centers and state government did a really good and fair job creating an updated PPS. They also then were able to create an environment where health centers were able to advance into advanced sort of two-sided ACO risk sharing They then introduced a primary care capitation based on the PPS plus an add-on of reimbursement. That has allowed health centers to do things like create new patient schedules to allow for longer visits with patients who need longer visits, and to also do things like hiring a bunch of behavioral health clinicians, and to Libby's point, non-clinical caregivers who are crucial to the care team, like family partners.
Thank you. Thank you. Dana, since NQF's inception in 1999, there's been a commitment to engaging patients, and I know that's challenging. I know we've had some good conversations about how difficult that is considering the technical nature of developing measures. Can you talk a little bit about some of the newer work that you're all doing to engage patients in your work?
Yeah, thanks so much, Libby. And I think you're right, that since 1999 and the inception of NQF, which was a moment in our country's history where it was a turning point. We were based on the President's Commission on Consumer Protection in Healthcare. We were saying we needed an entity that would be the nation's steward for healthcare quality measures to help us know which measures are good enough to be used for what I used to call in my academic and then in my Blue Cross days, high stakes purposes like payment, public reporting, network design to steer individuals to certain providers over others. How would we know if a measure is good enough for that? And I would say that the work of evaluating the measures themselves, it's always been critical to make sure that patients are at that table together with purchasers and payers and providers. But that's a hard conversation we've seen over 2 decades to really get patients engaged. And you wind up with, quite frankly, a very small number of individuals who represent patient perspectives and who are themselves becoming expert in all the statistics behind how you evaluate a measure. What we're excited about now at NQF is that the work that we're now focused on is what I've described as the work upstream and downstream from evaluating the measures. So the work upstream is, what are the measures that we need that we don't have? And the downstream work is, how do we put measures that we have to work to make care better, more affordable, more equitable? Those two conversations are ones that patients are very eager to be at the table. And we had the wonderful opportunity earlier this year to collaborate in that work. One of our initiatives in that upstream space is a coalition of payers and purchasers who are doing what I think the LAN community would appreciate as prospective alignment on measures, right? Before we develop a new measure, let's all agree on what's something that we really need and we all will commit to use. And even moreover, these payers and purchasers are committing that for any new measure that comes out of the work, that they will retire 2 or more measures from their existing measure set so as to not add burden. But a key part of that process allows us to then bring patients to the table to say, okay, relative to this gap area that's been identified, and in this first cycle of work that's been behavioral health outcomes, particularly depression and anxiety for children and adolescents, where we have no outcome measures in our nation's portfolio, and improving maternal health outcomes. We then could engage patients to say, you as somebody who's experienced this or whose child is experiencing this, what are the outcomes that matter to you? And then to use that to really shape the outcome measure concept that we're going to develop. I am finding, and through your organization's help, we are finding that patients are very eager to participate in that, and you can get just such a broad range of individuals from across the country, all different settings, all different age groups. And so I'm very excited about that work as well as the downstream work that we're able to do, where I think the conversation really matters to people and it's very tangible and relatable.
What a great advance in patient-family engagement. I think that's pretty incredible. To any of the panelists, what do you guys see as the major challenges that people encounter when engaging with providers and payers throughout the healthcare journey that can be addressed through design and implementation, kind of like what Dana just described?
Sure. I'll go first. I'll go back to framing again. First, I think it's important that patients and families be able to receive clear and concise and transparent information that actually resonates, and so that they can make healthcare decisions that are in their own best interest versus receiving it their passive receivers of information about their own care. Of course, we all in this room know that that lack of engagement can lead to things such as fragmented care. It can lead to more costs. It can lead to poor quality and not so pleasant experiences. I bring up framing because I think we typically approach engagement with the perspective of, well, we need to educate or provide patient education, without realizing that patients and families are not devoid of solutions. What they're devoid of is resources, social capital, and political will, so that they can enact some of their own solutions. And I think there's a whole lot that we can learn from them as well. I think I applaud us for where we are, for our progress, but I think we're at a place where we believe that we should, or trying to figure out how do we bring a patient to the table. I think it's time to push that paradigm, because I think the table is not inside of our boardrooms. I think the table is at picnics, it's at cookouts, it's at kitchen tables, and that's where healthcare decisions are being made. So how do we build trust with people in communities so that we get the invite to their table? Because the table have always belonged to them, and we're the guests. I think a real example of that, I think last week maybe I was asked the question of how do we provide better tactics and resources so that we can better manage high-risk patients. One, I think the question is very well intended, but I think even if we use corporate lingo or lean into, let's say, lean management, it's not one person who comes to work every day and say, I want to be managed. People want to be supported. They want assistance. They want help when they be, but no one wants to be managed. At best, we can manage processes, projects, and we all hope to be able to manage environments that we're in. I think it's the same with patients. They don't expect us to manage them. They expect us to help manage the complexity that they're trying to navigate of a system that most of us did not build it, but we're certainly stewards of it. Likened to that, the term high-risk patients puts the onus on the patient for the situations in which they're in, for the landscape that they're trying to navigate. It doesn't take into account those upstream factors that's created their living conditions, including social determinants of health. And we can go further upstream and talk about the regulations, the policies, the systems that's created those living conditions. And I can lean into some of my own belief, some of the commercialization that even drives some of that. So I think that's really, that understanding is really key. That framing helps us to ask the right questions and helps us to engage people transparently and authentically in ways that can build trust.
Wow, you said a lot right there, and I think it's so good. Yeah. So good. High-risk patients, non-compliant patients, that difficult mom, that, oof, I've been them all. I've been them all, but you know what, it just sidelines the whole partnership, yeah. Go ahead, Christina, challenges?
I mean, I can add on. I feel like it's going to sound very pedestrian after Brandon. One thing I was thinking about earlier was, so think of two shapes. One's a line. And the line is health insurance companies to provider organizations, right? Or call them carriers to ACOs, or however you want to frame that line. And how we might think about the evolution or the lengthening or the richness of the depth of that line to get to a more advanced alternative payment space, which is what we're all interested in, It's part of why we're here today. So there's another shape too, though, which is a triangle, which is the health insurance company, the provider group, and the patient, or the person, we're saying today the person. And that person, that on the line, there could be a very evolved line between the health insurance organization and the provider organization, where it's really uplifted from fee-for-service and evolved into value. And if the person is still paying a price that's a high deductible or a high coinsurance or a high copay, they may still be making choices based on what they can afford, regardless of whether their provider has become highly engaged around looking at their care gaps and understanding that this individual is due for a colonoscopy. If the price of the colonoscopy is going to be a price that's not affordable, right, then you're in the triangle, and you can't really advance the healthcare system for the people.
Thank you.
I'll be really quick.
Yeah, go
I
ahead.
was just going to say, based on, in my job previous to NQF, I was with Haven, the joint venture of Amazon, JP Morgan Chase, and Berkshire Hathaway. And one of the joys of that role was I got to be out all across America talking to people in jobs, in Amazon warehouse jobs, in Chase Bank teller jobs, and understand what do they experience in their healthcare? What are the biggest problems they face? And I think it comes down to three things. It comes down to cost, and we can't forget affordability. It comes down to fragmentation and the lack of coordination of care. And it comes down to the lack of whole person care, a kind of one-size-fits-all approach to care. And part of my own passion around value-based payment is I think it goes directly at all three of those things.
That's really helpful. We have a saying at our office, we want to standardize individualized care. That's really what we're getting to. We're pretty simple in our office.
Yeah.
That's right.
I'm sure all of y'all can do that, right? By Tuesday? All right, I know we're out of time, but could we just run really quickly and see if any of you have had some sort of compelling ideas for how to engage individuals, things that you've seen that have been really effective?
We need to go. I've been going first. I'll let you all go.
Okay. Well, here I think I'll draw from the years that I had the opportunity to lead a value-based payment model from my seat at Blue Cross Massachusetts. And what I saw organizations doing to really effectively engage patients was, first of all, to really change up their staffing model so that, we've heard a lot of that today, right? Integrating behavioral health providers, social workers, and others onto the care team, integrating pharmacists onto the care team. But then I saw them actually going out into the community to meet with people, as Brandon has said, at their table, not expecting, a kind of building-centered approach to care. So I think that's really one of the transformations that I think value-based payment can bring, is to free us up from the tyranny of the office visit.
What a great strategy.
I'd probably loop back in on being able to give healthcare providers the resources that they need to collaborate with community-based organizations, and giving community-based organizations the organizational capacity and the financial resources that they need to actually directly address social determinants of health that members of the community have, to help try to alleviate those issues, to then engage patients in their healthcare concerns, or people in their healthcare concerns.
Thank you.
Thank you. I'll close it with probably moving further upstream. I think we have a unique opportunity when addressing holistic care to look at the whole person, the whole family, the whole community, and history. So I think it's imperative that we begin to even consider historical context, and continue to do so, and structural racism over the long term. I say that, as she specifically asked about engagement, think about research that was done from from a researcher at Louisiana State University who looked at different towns and counties who had experienced a higher level of lynchings. And they found that in those same communities today, they have lower rates of community engagement. By way of that, lower rates of voting. And by way of that, lower rates of life expectancy. And when we think about then, well, that's a different time, but that was tyranny on the community that plays out in how they can engage with systems today. We may see that as a different system because we operate in systems. We love wonderful frameworks and language. But to people who've been harmed by systems, they experience it as a nexus, with a synergistic impact that's harmful for them. So how do we bring that context into how do we engage with people and communities to improve their health outcomes, their lives, their well-being, their community? So I think always having that lens, I think is really helpful, and it allows us to then lean into cultural competent care, which may look like having community health workers who are from my community, who speak my language, who understand the history and the nuances.
Thank you so much. You have all given us so much to think about, and as the HCPLAN Patient Perspectives Council gets underway, we'll take all of this to heart and really move forward in a way that is inclusive, in a way that doesn't require people to get to our table, as Dana mentioned, but building tables in the community so that the HCPLAN is ultimately informed by the community that it serves. So I want to thank all of you. It's an honor to be up here with you. Thank you.
Thank you.